all of you, and good morning and good afternoon who are from rest of the world. Today, our guest speaker is Dr. Vaishali Sanchorawala from Boston, USA. She's going to lecture us on AL amyloidosis. This webinar is brought to you by Mumbai Hematology Group, supported by Netco Oncology, and managed by Perfect Square. I thank Mr. James Rajkumar and Team Netco, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Vaishali Sanchorawala from Boston, USA. All our discussants were themselves eminent hematologists or medical oncologists, and you participants for sparing your Saturday evening and morning and afternoon if you're from the rest of the world. Not to forget, do visit our website, www.mhgindia.com, where you can access all our future educational activities and even past programs. Tomorrow, that is Sunday, 25th of September 2022, we have got an excellent lecture on high-risk myeloma by an excellent speaker, Professor Dr. Maria Victoria Matthews from Spain. Now it's a time and privilege to introduce all my discussants for the day. We have a galaxy of them. Starting with Dr. Aditya Jandial, he is hematologist at Department of Clinical Hematology and Medical Oncology, PGI Chandigarh. Dr. Bhausab Baigal, he is professor and consultant medical oncologist, Tata Memorial Center, Mumbai. Dr. Govind Patel, DM Clinical Hematology, AIMS, Delhi, assistant professor, Department of Hematology, Dr. S.N. Medical College, Jodhpur. Dr. Jatin Sarin, Director, Medical Oncology and Hematology, IV Hospital, Mohari, Chandigarh Cancer and Diagnostic Center, Chandigarh. Dr. Javed Rasool, he is professor and head, Department of Clinical Hematology, Sher-I Kashmir Institute of Medical Sciences, SKIMS, Srinagar, Jammu and Kashmir. Dr. K. Ashok Kumar, DM, Medical Oncology from Nizam's Institute of Medical Sciences, Hyderabad, Fellowship in Stem Cell Transplantation, CMC Vellore, Consultant Hematologist and Bone Marrow Transplant Physician at American Oncology Institute, Hyderabad. Dr. Lingraj Nayak, he is MD, DM, DNB, Assistant Professor, Department of Medical Oncology, Tata Memorial Hospital, Mumbai. Colonel Dr. Rajan Kapoor, Professor, Department of Medicine, Consultant Hematologist, Command Hospital, Eastern Command, Kolkata. Dr. Samun Jilani, Director, Hematology, Florence Hospital, Professor and ex-HOD, Clinical Hematology, SKIMS, Srinagar, JNK. Dr. Sanket Shah, Consultant Hematology, Oncologist, and Stem Cell Transplant Physician at HOC Vedanta, Ahmedabad. Dr. Shilpa Bhartiya, she is Consultant Hematologist, Parkview Super Specialty Hospital, Apollo Clinical Hospital, Kolkata. Dr. Sundar Shivale, MBBS, MD, DNB, Clinical Hematology and BMT resident at Tata Medical Center, Kolkata, ex-MUHS Fellow, Clinical Hematology, Lilavati Hospital, Mumbai, ex-SR, TMH, Mumbai, ex-Lab Hematology Fellow, TMC, Kolkata. Dr. Thomas Kuncheria, Senior Resident, DM Clinical Hematology at All India Institute of Medical Sciences, Bhubaneswar. Dr. Vinu Sarthi, he is Medical Oncologist at Bangalore Baptist Hospital, Bengaluru. Lieutenant Colonel Dr. Ashok Meshram, he is classified Special Medicine and Clinical Hematology at INHS Aswini, Kolaba, Mumbai. Now it's a time to introduce our guest speaker for the day, Dr. Vaishali Sanchorawala from Boston, USA. Dr. Vaishali Sanchorawala, she is Director of the Stem Cell Transplantation Program at Boston Medical Center. She is Director of Amyloidosis Center at Boston University School of Medicine. She is Skinner Professor of Amyloidosis Research in the Department of Medicine. She is Associate Editor of Amyloid, the Journal of Protein Folding Disorders. Secretary of the International Society of Amyloidosis for 2020 to 2022. Her research has led and defined the field in AL amyloidosis. She is recognized as one of the leading international experts and a key opinion leaders in amyloidosis. With numerous publications and meeting presentations, she is one of the pioneers in the field of clinical research in AL amyloidosis. Her work in the treatment of AL amyloidosis has resulted in the evolution of the standard of care for these patients. She is currently heading several clinical trials in the treatment of AL amyloidosis, two of which were conducted nationally through SWOG 0115 and SWOG 1702 and led to publications in peer-reviewed journals. She is part of the faculty at major international conferences in amyloidosis and has given many invited talks at national and international meetings. She is very active in various non-profit organizations, regulatory authorities, and funding bodies as an expert on amyloidosis. She is at present a member of the Executive Steering Committee of Amyloidosis Research Consortium, which is developing pathways to education, patient voice, development of treatment, and access to novel therapies. She has helped to create and cultivate the next generation of physician scientists in the area of clinical research in amyloidosis. She regularly attends several patient information seminars and support group meetings in US. Outside of roles of direct research and clinical care, she has an interest in working in charity organizations. She did her MBBS from St. G.S. Medical College, KM Hospital, Mumbai, India, followed by she did her residency at University of Medicine and Dentistry of New Jersey. Then she did her fellowship in hematology oncology from Boston Medical Center, and then she did her fellowship in stem cell transplant from Boston Medical Center. It's my privilege to invite her to deliver her lecture on AI amyloidosis. Over to you, ma'am. Thank you so much.
Okay, let me see if I can share my screen. Are you able to see the screen?
Yes.
Yes, ma'am, we are able to see the screen.
Okay. So good morning, good afternoon, good evening to all of you. I thank the organizers of Mumbai Hematology Group, specifically Dr. Agarwal and Dr. Khurana, for inviting me here to share some of my experiences and science in AL amyloidosis. As Dr. Khurana gave a very, very kind introduction, I am from India, and this is a deep honor and privilege for me to be speaking to all of you about my career and advances in this field. I've been working in amyloidosis since 1994. And as I was telling Dr. Khurana earlier, that this is, the destiny that, I have landed in this field since 1994. These are my disclosures. I get research support from several companies, and I'm also on scientific advisory board for several pharmaceutical companies. I will begin by this cartoon, which is a cartoon of average physician's approach to the patient with amyloidosis. This is a patient who has macroglossia and raccoon eyes, and he goes to his family practitioner or primary care doctor, and the primary care doctor tells him, there are some things they don't teach you in medical school. I think you've got one of those things. So the road to diagnosis of amyloidosis can be quite rocky. Because AL amyloidosis remains a rare disease, even in 2019, from the Mayo Clinic group in Olmsted County of Minnesota, the incidence of AL amyloidosis, it remains at 1.2 per 100,000 person years. Amyloidosis Research Consortium, led by actually one of the patients that I had treated in 1996, did an online social media survey of all patients with amyloidosis and showed that time from initial symptoms to diagnosis of amyloidosis. One second. Okay. Yeah. So the time from initial symptoms to diagnosis of amyloidosis was greater than 12 months in 40% of the patients. Moreover, the number of physician visits before establishment of diagnosis was greater than 2 in 60% of the patients. And even more surprisingly, the specialty that diagnosed amyloidosis was consisting of hematologist oncologists in 30% of the patients. However, the primary care doctors and cardiologists and neurologists, where the clinical symptoms usually present with, really were in minority in diagnosing these patients. So this survey indicated significant delay, and multiple physician visits before diagnosis of amyloidosis was established. So the outline of my talk is going to focus on advances in pathogenesis, updates in diagnostics, typing, staging, and risk stratification, and then focus on treatment, which would be divided into definitive treatment and supportive treatment. So amyloidosis is a term for diseases that share a common feature of extracellular, insoluble, pathologic amyloid fibril deposition derived from normally soluble precursor protein. These extracellular amyloid fibrils are cross-beta sheet pleated, and hence when stained with Congo red dye gives rise to apple green birefringence. There are 36 different amyloidogenic precursor proteins identified, which are associated with amyloid-related diseases. There are many other proteins that can also form amyloid-like aggregates. On the right, you can see the Congo red stain. When seen under H&E stain under regular light, it shows up as salmon pink appearance. Under electron microscopy, these amyloid fibrils are 8 to 10 nanometer in diameter, non-parallel, and are randomly deposited. International Society of Amyloidosis and its nomenclature committee have divided amyloidosis into systemic forms and localized forms. Systemic amyloidosis is defined as amyloid fibril deposition occurring in the organs away from the site of precursor protein production. The most common form of systemic amyloidosis is AL amyloidosis, where amyloid fibril deposition occurs in kidneys, heart, liver, GI tract, nervous system, soft tissue, which is away from the precursor protein production, which is the bone marrow plasma cells and immunoglobulin light chain amyloidogenic protein production. The next most common form of systemic amyloidosis is hereditary amyloidosis or familial amyloidosis, where the most common form is transthyretin amyloidosis, where amyloid deposition occurs in the heart or nerves, and the precursor protein production is usually the liver, where the mutant or variant transthyretin protein is produced. In contrast, localized amyloidosis is defined as amyloid fibril deposition occurring at the site of a precursor protein production. The most common form of localized amyloidosis is Alzheimer's disease, where amyloid plaques are deposited in the brain and are derived from A beta protein precursor, which is also being produced in the brain. There are other uncommon forms of localized amyloidosis which affect the tracheobronchial tree, airway, urinary bladder, ureter, spleen, breast, and these are arising from the plasma cells at the site of production, at the site of deposition of amyloid fibrils. The International Society of Amyloidosis and the Nomenclature Committee meet every 2 years, and this classification is updated. The incidence and prevalence of amyloidosis. So the incidence of AL amyloidosis in a US population with commercial and Medicare supplement insurance published in 2018 shows that the incidence has remained stable over last 9-year period, ranging from 9.7 to 14 cases per million person years. However, the prevalence of AL amyloidosis has increased significantly over this 9-year period from 15.5 to 40.5 cases per million, again suggesting that patients with amyloidosis are living longer because of advent of new therapeutics. Now going on to pathogenesis of AL amyloidosis, it arises from a dangerous small B cell clone in the bone marrow, which produces kinetically or thermodynamically unstable light chains, which then interact with cellular and extracellular matrix proteins and extracellular chaperones to form soluble oligomers. These soluble oligomers then interact with serum amyloid P protein and glycosaminoglycans to form amyloid fibrils. The mechanisms for organ dysfunction are either related to amyloid fibril deposition, disrupting the architecture of the affected organs, leading to organ dysfunction, or direct cytotoxicity of the soluble precursor proteins or oligomers on the affected organs. Now, there have been several models that have shown the precursor protein toxicity on the end organs. These are the two models. One is C. elegans or worm that has shown from the Italian group showing amyloidogenic precursor protein affecting the cardiac muscle contractility and relaxation in C. elegans, as well as from the Harvard group on zebrafish model showing cardiac toxicity even prior to amyloid fibril deposition. So this was an instantaneous affection of the cardiac muscles by affecting their relaxation and contractility before the amyloid fibrils were formed. The light chain stability determines susceptibility to amyloidosis, either because of misfolding, fluctuations, or monomerization. The light chains are then becoming protease labile, undergoing proteolysis, leading to formation of amyloidogenic fragments, and then aggregation, leading to soluble oligomer formation, causing amyloid fibril deposition. The clinical presentations of AL amyloidosis could be quite vague or could be very specific. The most common organs that are involved with AL amyloidosis are kidneys and heart. Kidneys are involved in 60 to 70% of the patients, whereas heart is involved in 70 to 80% of the patients. There are several particular clinical syndromes that are typical for AL amyloidosis. One of them is spontaneous periorbital ecchymosis, also known as raccoon eyes. This raccoon eyes happen because of capillary fragility related to AL amyloidosis. Macroglossia, depicted over here as indentation of teeth mark on the lateral borders of the tongue, also quite characteristic of AL amyloidosis. Submandibular gland enlargement and macroglossia, again characteristic for AL amyloidosis. And acquired factor 10 deficiency leading to coagulopathy and bleeding diathesis, again very, very typical for AL amyloidosis. We must also differentiate AL amyloidosis from hereditary ATTR amyloidosis, which is also called zebra of many stripes because of many clinical phenotypes associated with particular mutations in transthyretin protein. And as shown by Mark Semigran in this editorial, that patients who have particular mutation in transthyretin can either present with cardiomyopathy or they could present with autonomic and peripheral neuropathy. One particular mutation that I would like people to know about is V122I in transthyretin, which is extremely common in about 4 to 5% of African American patients, and the V30M mutation, which is common in Portuguese patients, individuals. Again, the clinical phenotypes of this type of hereditary ATTR variant amyloidosis differ. V122I ATTR amyloidosis leads to cardiomyopathy, whereas V30M ATTR amyloidosis leads to neurological manifestations. The diagnosis of AL amyloidosis is 2 steps. The first is the tissue diagnosis. One must demonstrate congophilia or Congo red positive material in the tissue diagnosis. Once the tissue diagnosis of amyloidosis is obtained, it is absolutely crucial to identify the amyloid precursor protein unequivocally, because it is important to do this, because for appropriate treatment, to assess prognosis, and to offer genetic counseling when appropriate. As stated earlier, there are 36 different amyloid precursor proteins. The most common ones are listed over here: light chain, transthyretin, and serum amyloid A protein. The typing of amyloid deposits, once the tissue biopsy is obtained, can be done either with immunohistochemistry, which is unreliable with commercial antibodies, or with ultrastructural electron microscopy immunohistochemistry with gold label antibodies, which is available only at Boston University and in Pavia, Italy, which is quite specific to identify accurately the amyloid precursor protein in 99% of the times, even with commercial antibodies. And the most gold standard and up-to-date amyloid typing method is mass spectrometry, AFT-based proteomics after laser microdissection. And this is not antibody dependent. The specificity is over 99%, and this is considered the gold standard for accurately typing the amyloid precursor protein. Obviously, high index of suspicion is important and necessary to identify amyloidosis. Suspect amyloidosis with unexplained nephrotic syndrome in the absence of diabetes, hypertension, restrictive cardiomyopathy, leading to congestive heart failure, neuropathy, acquired coagulopathy, and weight loss. High index of suspicion is critical to identify patients with amyloidosis. Once you suspect amyloidosis, the next step is to perform tissue diagnosis. Fat pad aspiration is a bedside procedure which is done under local anesthesia, takes less than 5 minutes to perform. And when this abdominal fat pad aspiration is subjected to Congo red staining, it is usually positive in 70 to 80% of patients with systemic AL amyloidosis, needs to be subjected to Congo red staining and then examined under light microscopy as well as polarized light microscopy. And as shown here, showing salmon pink appearance when subjected to light microscopy, and apple green birefringence when subjected to polarized light microscopy. However, if abdominal fat pad aspiration is not demonstrating congophilia and clinical index of suspicion is high, one must perform a biopsy of the affected organ, either the kidneys, if there is a presentation with nephrotic syndrome, or the heart, if it is presented as cardiomyopathy. The plasma cell dyscrasia clone in AL amyloidosis is very small. The median number of plasma cells in the bone marrow are 10%, and 20% of patients with AL amyloidosis have less than 5% plasma cells. This table is from all leading institutions: Pavia, Boston University, Mayo Clinic, and Heidelberg, Germany, suggesting that serum and urine immunofixation electrophoresis and serum-free light chain assay can identify plasma cell dyscrasia clone in AL amyloidosis in 98% of the patients. However, there is a new mass spectrometry-based technique performed at Mayo Clinic laboratories that can increase diagnostic sensitivity from 98% to almost 100%. And these are the different techniques that are not always available, but as shown here, the serum protein electrophoresis, the level of detection of a monoclonal protein is 0.5 grams per liter, whereas immunofixation has level of detection increased by 100 times with monoclonal protein detection of 0.05 grams per liter, and two mass spectrometry-based techniques, which are not yet FDA approved and not available for commercial use except at Mayo Clinic laboratories, are mass fix and MyRAM. Both these techniques have increased the levels of detection dramatically in patients who do not have presence of plasma cell dyscrasia identified by traditional, more available techniques. There also have been advances in imaging in identifying cardiac involvement from amyloidosis. As you all know, cardiac involvement is the driver for survival in patients with amyloidosis. The advances in imaging are based on echocardiography, MRI, and other imaging modalities. The cornerstone for diagnosis of cardiac involvement in amyloidosis is echocardiography. There is a new technique of strain Doppler imaging that shows the apical sparing with cherry on top appearance suggestive of cardiac involvement, cardiac amyloidosis. Cardiac MRI with T1 mapping shows late gadolinium enhancement, either patchy or diffuse, which is typical for infiltrative cardiomyopathy. Non-biopsy diagnosis of transthyretin cardiomyopathy was performed by bone scintigraphy, and in the United States, we have technetium pyrophosphate scan, which again is typical for diagnosis of transthyretin amyloidosis. Usually in patients with AL amyloidosis, this scan is negative. Also on the research side, there is a PET-CT imaging with 18F fluor beta pair radio tracer, which leads to presence of, which leads to positive imaging for cardiac involvement in AL and TTR amyloidosis. Again, these techniques are not available for commercially. As stated earlier, cardiac involvement and cardiomyopathy remain the driver for prediction of overall survival in patients with AL amyloidosis. Biomarker-based staging systems have been developed in renal involvement as well as in cardiac involvement to prognosticate patients with overall survival. The first staging system that was developed was Mayo 2004 staging system, which was updated by the European investigator based on cardiac biomarkers of N-terminal pro-brain natriuretic peptide and troponin T. And depending on the thresholds, they were differentiated into three stages, with stage 3B with NT-proBNP of greater than 8,500 picograms per ml, which predicted and differentiated patients with AL amyloidosis in survival categories. And as stated here, the stage 3B cardiac AL amyloidosis patients have a median survival of 5 months. This staging system was updated by the Mayo Clinic investigators in 2012, which now incorporated the markers of plasma cell dyscrasia with difference in involved and uninvolved light chains of greater than 180 milligrams per liter, elevated NT-proBNP and troponin T, again, differentiating patients into 4 different stages and predicting for overall survival. At Boston University, we were not able to perform NT-proBNP, and hence we developed the staging system with BNP, or brain natriuretic peptide, and troponin I. And again, we were able to differentiate patients into 4 stages, predicting for overall survival. Stage 3B in this staging system has BNP threshold of greater than 700 picograms per ml and troponin I threshold of more than 0.1 nanograms per ml, with a median survival of less than a year. Biomarker-based staging systems also have been developed for renal involvement, and these biomarkers are estimated GFR and 24-hour urine protein excretion. And based on these biomarkers, patients were divided into 3 stages, which were able to predict 2-year risk of end-stage renal disease needing dialysis and annual risk thereafter. And as shown here, patients with stage 1 disease have a 2-year risk of dialysis of 0 to 3% and annual risk of 0 to 1%. In comparison, stage 3 patients have 2-year risk of dialysis of 60 to 75%. Moving on to treatments. So each and every step in the pathophysiology of amyloid fibrinogenesis can be a potential treatment target. We are going to currently focus on the soluble precursor protein, i.e. the plasma cell dysplasia, as the treatment target. Before we move on to treatments, we must remember that early diagnosis and correct typing are absolutely crucial in improving outcome of patients with AL amyloidosis. You do not want to treat patients with transthyretin amyloidosis with chemotherapy that is directed against plasma cell dysplasia, as the pathophysiology does not make sense. Moreover, there is a fine balance of chosen treatment regimen and patient's ability to bear toxicity. Moreover, it is important to remember the definitions of hematologic response and organ responses. It is important also to note that majority of our treatments are focusing on hematologic response and ablation of plasma cell dysplasia. However, what is deposited in the organs are not being addressed at this time. It is important to also note that organ or clinical response may take 3 to 12 months after achievement of a hematologic response. Moreover, hematologic complete response is not always needed to achieve an organ response. As shown here, the median time to organ response from start of treatment is approximately 10.4 months, ranging from 8 to 13 months. International Society of Amyloidosis have validated and unified the hematologic as well as cardiac and renal response criteria, and they are listed over here. It is important to note that these are based on biomarkers of plasma cell dysplasia based on serum free light chain assay. These criteria were validated in Europe as well as in United States, and these are the survival curve data. So FLC-based or serum free light chain-based hematologic response criteria can lead to improvement or can lead to prediction of overall survival when patients are treated with non-stem cell transplant regimen, as shown by Dr. Palladini and his colleagues, and as shown by my colleagues at Boston University after stem cell transplantation. So complete hematologic response predicts for overall survival compared to patients who develop who achieve a partial hematologic response or no response after treatment. Hematologic response criteria recently have also undergone some revisions and refinement. There are some low serum free light chain endpoints that are developed, and I have summarized them in this table. These were developed by UK National Amyloidosis Center, Mayo Clinic, University of Pavia, and Boston University at my institution. Again, either with difference in free light chain levels of less than 10 or involved free light chains of less than 20, they predict for better overall survival than standard routine traditional hematologic criteria. More on minimal residual disease measurements or more on hematologic response measurements. Minimal residual disease measurement, this is the data from my institution. Again, we perform minimal residual disease measurement from 10-color multiparametric flow cytometry, and MRD negativity at 10 to the -5 is associated with improved progression-free survival and higher probability of achievement of organ responses. These data were updated at the recent International Society of Amyloidosis in beginning of September in Heidelberg, Germany, from my co-investigator, Dr. Staran, showing that again, MRD negativity led to better organ responses, specifically renal response, as well as hepatic response, and also leading to major organ deterioration, progression-free survival with a hazard ratio of 0.29. Renal response criteria also have been updated based on renal biomarkers. Again, renal response defined as greater than 30% decrease in proteinuria to below less than 500 milligrams per 24 hours in absence of renal progression, again, predicting for 2-year risk of dialysis and 5-year risk of dialysis, showing that renal response leads to 3 to 10% 2-year risk of dialysis and 5 to 10% risk of dialysis at 5 years. Whereas if there is renal progression following treatment, the 2-year risk of dialysis increases to 25 to 40%. Similarly, cardiac response based on biomarkers, either NT-proBNP or BNP, can also lead to improvement in survival. In contrast, if there is progression of cardiac biomarkers, it is associated with poorer survival. There have been several novel biomarkers which predict for survival in AL amyloidosis. One of them is growth factor differentiation factor 15, which is a new prognostic factor, and its reduction after therapy is associated with better outcome. Another one, which is routinely available, is D-dimer, which is elevation in AL amyloidosis is independently associated with decreased survival. These are the data from my center. And again, the hypothesis is that there is endothelial dysfunction leading to elevation of D-dimer, and this is associated poorly with survival in patients with AL amyloidosis. Now, as stated earlier in the second slide or third slide, that the prevalence of AL amyloidosis has increased in the last 15 years. And we also have seen, this is data from my institution, that the overall survival and outcome of patients with AL amyloidosis has improved dramatically in the past 40 years. In the 5-year overall survival was 15% in the first era of 1980 to 1989 and has improved to 48% in the most recent era of 2010 to 2019. Similarly, the median overall survival has also improved, and we owe this improvement in overall survival for patients with AL amyloidosis to the very effective therapies against the clone, which is the plasma cell dyscrasia, and majority of these treatments are derived from those of approved treatments for multiple myeloma. This is the therapeutic landscape that has expanded dramatically in patients with AL amyloidosis from the 1990s to 2022. And as you can see in the top part of the slide is that the response rates, the hematologic response rates also have improved drastically. This is a very, very basic algorithm for guidelines for initial treatment of patients with AL amyloidosis. Again, accurate typing and accurate diagnosis is crucial. Patients should then be divided into transplant eligible versus transplant ineligible, and we will go over all the details about this. Again, the goal is to achieve a greater than hematologic VGPR, and then we will talk about relapse refractory patients with AL amyloidosis. Conventional treatment prior to 1990s was based on 2 historical pivotal randomized clinical trials of oral melphalan prednisone compared to colchicine in patients with newly diagnosed AL amyloidosis. One trial was conducted by Professor Skinner at Boston University. Another trial was conducted by Professor Kyle at the Mayo Clinic, showing that oral melphalan and prednisone can improve median overall survival to 12 to 18 months compared to placebo or colchicine, which was 6 to 8 months. Moreover, however, this treatment led to hematologic complete responses rarely, and long-term survivals were also less than 5%. We at Boston University presented this data at the International Society of Amyloidosis meeting in Heidelberg, Germany in first week of September, showing our experience of 648 patients with AL amyloidosis undergoing high-dose melphalan and autologous stem cell transplantation, showing a median overall survival of 7.6 years, as shown in the left panel, and 10-year overall survival of 67% patients after undergoing stem cell transplant in the most recent era from 2012 to 2021. Moreover, the treatment-related mortality, defined as deaths occurring within 100 days of stem cell transplant, has decreased from 13% to 7% to 5% to less than 3% in the most recent era. This is attributable to better post-transplant supportive care and also better selection of patients with AL amyloidosis for this impressive treatment. Stem cell transplant data also has been published from CIBMTR registry data of 1,500 patients, again showing improvement in 5-year overall survival from 55% in the early 1990s to 77% in mid-2000s. This also has been shown by the Mayo Clinic group that the estimated overall survival at 15 years is 33%, and again shown by UK National Amyloidosis Center that the median overall survival is 8.2 years and long-term survival at 20 years is 32%. However, it is important to note that because of organ dysfunction, because of organ failure, and because of poor performance status, only 20% of patients with new diagnosis of AL amyloidosis, even at my center, are eligible to undergo aggressive treatment with stem cell transplantation. 80% of the patients are treated with less aggressive treatment with non-stem cell transplant regimens. And these are two pivotal publications. These are not randomized trials, but pivotal publications from the European group on oral melphalan dexamethasone and combination of cyclophosphamide bortezomib dexamethasone, showing that the complete hematologic response with melphalan dexamethasone, but dexamethasone is used in an attenuated low-dose weekly fashion, is 12%, and hematologic complete response is 19% when patients are treated with Cybol-D and when bortezomib is given as weekly 1.3 milligrams per meter square dosing. Oral melphalan and dexamethasone, when given as attenuated schedule, leads to median overall survival of 20 months, and in Cybol-D publication, the median follow-up of 25 months. The overall survival at 3 years was 55%, with a median progression-free survival of 13 months. UK National Amyloidosis Center published their data a few years ago on 915 patients with new diagnosis of AL amyloidosis treated with upfront bortezomib-based therapy, showing a complete hematologic response in 25% of the patients and 20% of the patients achieving a very good partial response. Median time to next treatment was not reached in this large cohort of patients, with a median overall survival of 72 months. European Myeloma Network also published a 109 patients randomized clinical trial of new diagnosis of AL amyloidosis who were randomized to be receiving bortezomib melphalan dexamethasone versus melphalan dexamethasone with an overall hematologic response very good partial response plus complete hematologic response, overall survival, and progression-free survival, favoring bortezomib, melphalan, dexamethasone compared to melphalan, dexamethasone. This Andromeda clinical trial, published in the New England Journal of Medicine, has revolutionized the treatment of patients with AL amyloidosis. This is a randomized clinical global trial of cyclophosphamide, bortezomib, dexamethasone plus subcutaneous daratumumab versus cyclophosphamide, bortezomib, dexamethasone in patients with newly diagnosed AL amyloidosis. And this trial has been updated recently with a longer follow-up showing that hematologic response rates, complete hematologic response rate, which was the primary endpoint of the trial, is significantly higher with DVCD group compared to VCD group, ranging from 53%, deepening it to 60% with a longer median follow-up. Similarly, the organ response rates also continued to improve with daratumumab, cyclophosphamide, bortezomib, dexamethasone compared to Cyborg alone, with cardiac response rates of 53% and renal response rates of 58% at 18 months. However, it is important to note that half of the patients, despite having hematologic responses, do not achieve organ responses. And this is based on the pathophysiology that the amyloid fibril deposition remains outside the cells, pathologic insoluble deposition that is not touched by the chemotherapy regimens. Now, moving on to treatment of relapsed AL amyloidosis. This is a pivotal trial, CAN 2007, performed in early 2000s, which showed that the single agent bortezomib produced durable hematologic responses and promising long-term overall survival in patients with relapsed AL amyloidosis. Moreover, in this trial, once weekly bortezomib was better tolerated and produced similar responses to twice weekly bortezomib in relapsed patients with AL amyloidosis. This is a pooled analysis of 3 prospective clinical trials of immunomodulatory agents performed at Boston University. One trial was for Revlimid or lenalidomide dexamethasone. Other one was for melphalan, lenalidomide dexamethasone. And the last trial was for pomalidomide dexamethasone in patients with relapsed AL amyloidosis. And this pooled analysis showed a median overall survival of 4.3 years with a median progression-free survival of 2.1 years. This was a phase 3 randomized placebo-controlled clinical trial of Tourmaline AL1, which was a trial of ixazomib dexamethasone versus physician's choice treatment of patients with relapsed AL amyloidosis. And in this trial, the physician choice treatment included either thalidomide dexamethasone or cyclophosphamide dexamethasone or lenalidomide dexamethasone or dexamethasone alone. And unfortunately, this trial did not meet its primary endpoint, which was complete hematologic response. However, the primary endpoint, was the overall hematologic response, which it did not meet. However, complete hematologic response, median duration of hematologic response, the vital organ progression-free survival, and hematologic progression-free survival were all in favor of ixazomib dexamethasone versus physician choice arm. Daratumumab has also revolutionized treatment of patients with relapsed AL amyloidosis. Dr. Becklecker from UK National Amyloidosis Center and I have written a spotlight in Blood Journal, and we combined all the published reports on daratumumab in AL amyloidosis, and 625 patients were included in this publication, which shows that the hematologic overall response rates with single agent daratumumab is about 90%, and complete hematologic response rate is about 40 to 50%. Moreover, that this is an aggregate of all studies. This is not a randomized clinical trial. but monotherapy in relapsed AL amyloidosis with daratumumab is extremely effective in inducing hematologic responses as well as organ responses. Bendamustine is an alkylating agent. A phase 2 small clinical trial of 28 patients with relapsed AL amyloidosis were treated with bendamustine for 6 cycles, leading to complete hematologic response in 11% of the patients and very good partial response in 18% of the patients. And patients who achieved a hematologic response had better overall survival than patients who did not achieve a hematologic response. Venetoclax is a small molecule. It's a BCL2 inhibitor, which also has been shown to be effective in AL amyloidosis. As you know, that AL amyloidosis harbors translocation 1114 in over 50% of the patients. And when patients with translocation 1114 are treated with venetoclax as in the relapse setting, the very good partial response and complete hematologic response occurs in 78% of the patients. This was a multi-center retrospective analysis of venetoclax in AL amyloidosis. However, now prospective clinical trials are on its way to be assessing the efficacy of venetoclax in AL amyloidosis. However, as stated many times during this presentation, we need to look beyond plasma cells because amyloid organ or amyloid deposits in the organs leads to organ dysfunction, organ failure, decrease in survival, and death, affecting also quality of life. There were multiple clinical trials that were ongoing in 2016, and this is from Brandon Weiss's paper in Blood, that gives you novel anti-amyloid agents in clinical trials for AL amyloidosis, which were also known as amyloid busting agents or amyloid antifibril agents. Unfortunately, most of these trials have been stopped either because of futility or because of completion of accrual and again, not showing benefit or because of issues with tolerability. And these are monoclonal antibodies, and there are some of them are fully humanized monoclonal antibodies, some of them are chimeric antibodies, but these clinical trials were not really shown to be beneficial in patients with AL amyloidosis. Nonetheless, there are several clinical trials that are currently ongoing for patients with newly diagnosed AL amyloidosis, with advanced cardiac amyloidosis, where patients are randomized to be treated with standard of care treatment, which is Cybordi plus daratumumab, plus or minus amyloid antifibril agents. One of them is Calum 101, which is undergoing phase 3 randomized clinical trials, and also biltamimab, which is NEOD001, the last 3 drugs listed on this table, and that is also undergoing a phase 3 clinical trial currently in patients with Mayo 2012 stage 4 patients. Supportive care remains a fundamental part of an integrated treatment approach, which requires coordinated expertise of several subspecialists familiar with this disease. The goals of supportive care are to improve organ function, maintain quality of life, and prolong survival. So this is absolutely crucial because, as stated earlier, the organ responses may take 12 months to occur, and only 50% of the patients do develop organ responses following achievement of hematologic responses. So supportive care is absolutely fundamental in improving quality of life. And this leads to the multidisciplinary program components at Boston University Amyloidosis Center, where patient is seen under one roof by all the subspecialists in 2 to 3 days of prolonged outpatient comprehensive evaluation. And this is the team which I would like to acknowledge, which work on the scenes and behind the scenes to make an impact on patients with systemic amyloidosis. Thank you very much for your attention, and I will stop sharing my screen.
Thank you so much, ma'am. That was an excellent presentation. What a flow, what a presentation, what an update. You are always superb, always pleasure to listen to you. Every time when we listen to you, it's always new things coming up, and we learn so many things from you. Thank you so much.
Thank you so much.
Thank you. Excellent lecture, man. Thank you so much. You've got some few Indian colleagues who are going to bother you with questions.
No problems at all.
So we'll start with some delegates first. So I request all the delegates to please, participants to please open up the videos and raise hand signs if you've got any question. In the meanwhile, we'll take some from the audience. Dr. Karim has a question. 38 years female with primary amyloidosis, treated with Cybodex, 6 cycles, heart and kidney not involved. Now she is good. Any role of maintenance treatment?
Right. So I think it's the, I think the next question is the same one. So, I didn't really have time to go into details about induction therapy, maintenance therapy, consolidation. And I know that Marivi is going to be speaking tomorrow about high-risk myeloma. So, there's going to be a lot of, not really clash, but there's going to be a lot of information about induction therapy and the role of induction therapy in multiple myeloma, as well as maintenance therapy. AL amyloidosis, as I stated earlier, is a plasma cell dysplasia with low tumor burden, low plasma cell burden. Majority of the patients have less than 10% plasma cells. And therefore, there is no role for maintenance therapy in patients who achieve a complete hematologic response or patients who achieve at least very good partial hematologic response, defined as difference in involved and uninvolved light chains of less than 40 milligrams per liter. Now, patients who do not achieve VGPR or CR and achieve partial hematologic response, we don't call it really maintenance therapy. We would call it a second line treatment because we would recommend treatment. So role of maintenance therapy after achievement of a VGPR or CR post primary therapy is not existing.
Thank you so much, ma'am.
Because I also feel that, because the organs are so beat up that, patients, your goal is to really do abbreviated, 6 cycles, 8 cycles of treatment and not continuously treat them because they need time to recover. They need time for the organs to recover. So.
Thank you, ma'am. Dr. Aditya Jindyal, your question, please.
Thank you, ma'am, for the fantastic talk, as always. So my question is regarding one of the patients that we saw at PGI Chandigarh recently. So in your initial slides, you mentioned about the common channels through which the patients with amyloidosis are referred to hematology clinic. They are like cardiology, gastroenterology, nephrology. Recently, we had one patient who was referred to us from the pulmonary medicine clinic, the first of its kind. She is a 52-year-old lady with 2 years history of shortness of breath on exertion, and on imaging was found to have some GGOs on HRCT chest. And since there was no obvious cause of shortness of breath, the team had gone ahead with the open lung biopsy, which revealed lambda restricted amyloid in the interalveolar septa. And subsequently, she was found to have elevation of lambda light chains in the peripheral blood. And we later worked her up, and instead of plasma cells, we found lambda restricted abnormal lymphocytes in the bone marrow. So my 2 questions for this patient are, first of all, what is the usual light chain burden that you see in patients who are having amyloid in the setting of non-plasma cell clone like LPL or Waldenstrom? And second is how commonly you see pulmonary amyloid in your practice, and how do you measure the organ response in such patients?
Wish I could tell you more than what you are telling me. So pulmonary AL amyloidosis is rare. It's not very common. We see it either as refractory pleural effusions, which are refractory to medical management because there's a lot of amyloid deposition in the visceral pleura, parietal pleura, so that absorption of the pleural fluid is not happening. Or we see them as alveolar septal, just the way you presented ground glass opacities, or an amyloidoma as a pulmonary lung node. The unfortunate part is that it is so rare that there are no, obviously, prospective trials on it really suggested. Now, we also do see localized pulmonary amyloidosis, meaning that the plasma cells in the lungs or any cells in the lungs, they produce the amyloidogenic protein, and the amyloid fibril is happening right at the site in the pulmonary tissue. Those patients do not have evidence of systemic plasma cell dyscrasia, meaning that their immunofixations are negative, they do not have elevated serum free light chains, and obviously the bone marrow is negative. In your patient has lymphocytes. What is the lymphocyte? Is it CD5 positive, CD10 positive? So is this like CLL type of lymphoma, or is it Waldenstrom's type of lymphoma, lymphoplasmacytic, marginal zone? Most of the time, pulmonary involvement is with marginal zone lymphoma.
So
again, you have to attack, since this person has lymphoproliferative disorder associated AL amyloidosis, the treatment is directed towards the lymphoma clone. So which would be, again, I think probably rituximab-based treatment. But how do you measure responses? I think it would be based on high-resolution CAT scans, pulmonary function tests, and obviously patient symptoms.
Ma'am, just in continuation of the questions that I asked, because in a significant proportion of the patients, you mentioned that the plasma cell burden may be less than 5%, and in some patients we might not actually pick up the plasma cell clone. So my question is, like, if the lambda light chain level is, like, in this patient we had 3000, it was close to 3000, and the kappa lambda ratio was 0.003 at baseline. So do we generally see such a high light chain load in the setting of lymphocyte driven amyloidosis, or does it like fall in the bracket of plasma cell driven amyloid?
Right, it is very hard to distinguish that, since you demonstrated lymphocytes which are lambda restricted clonal in the bone marrow. I would still, again, I think that 3000 is very high even for a plasma cell clone. And then we always kind of feel that could this be like close to myeloma, because the involved versus uninvolved light chain ratio is going to be greater than 100 probably in this case. So I think that, again, I think it is, but I would still, because the demonstrable clone is clonal lymphocytes in the bone marrow. Does she have also a peripheral blood involvement from lymphoma or lymphoproliferative disorder?
No, ma'am. There is no organomegaly or some other. We had proteinuria. We actually went ahead with the renal biopsy, and that again shows lambda restriction with the deposition of amyloid in the glomeruli as well as in the vessels. So actually we gave her DARA VCD as first cycle, and then we debated the option of giving something like rituximab, Dexa, or we continue with the DARA VCD.
BDR would be a good choice. I think BDR would be a good choice, which you're attacking plasma cells as well as the lymphocytes. Yeah. So I think she needs something for the lymphocyte or lymphocyte clone.
Right. Thank you, ma'am.
So we see this in about 5% of patients, that it's associated with lymphoproliferative disorder. And the lymphoproliferative disorder we've seen is CLL, we've seen it in Waldenstrom's, we've seen it with marginal zone lymphoma. Marginal zone lymphoma and pulmonary involvement, they go hand in hand.
Thank you, ma'am.
Thank you, Dr. Aditya. Dr. Shilpa, your question, please. You're mute. Yeah.
Yeah, so sorry for that. Thank you, ma'am, for this deliberation. It was excellent. I have two questions. Once, if we have done a bone marrow and we've seen plasma cells and we send it for cytogenetics like we do it now as a standard fish panel analysis, and we see the high risk cytogenetics that we often seen in myeloma, do they have an impact on the severity of the disease in amyloidosis if we find these high risk cytogenetics? So do they have the same impact as they have in myeloma, as they have in the severity of the amyloid? That is my first question.
Right. So, I didn't present all that data as well, but translocation 1114, which is considered standard risk in myeloma, is greater than 50% of the times in AL amyloidosis. Translocation 1114 AL amyloidosis usually has worse outcomes with bortezomib-based therapy. They respond better to daratumumab, they respond better to high-dose melphalan, alkylating agents, and obviously venetoclax. Gain1Q, which is not part of high-risk cytogenetics in multiple myeloma. In AL amyloidosis, we see that in about 30% of the patients, and they do not respond very nicely with daratumumab. Again, are we there yet to develop personalized therapies based on cytogenetic abnormalities? No, we are not. But when I have patients with translocation 1114, if I treat them with bortezomib-based therapy, I am very quick in assessing responses in first 2 to 4 cycles. And if there is not enough response, meaning that there is not VGPR or CR within first 4 cycles, I am ready to change therapy.
Oh, yeah, thank you very much, ma'am. The second question was those who present really late. So they've got multi-system involvement, they've got cardiac involvement with severe hypertension, they've got GI involvement with diarrhea, and they've got significant proteinuria and ascites. I mean, these people, would your approach be different? Because, tolerance to therapy itself is so difficult that, you try to correct one thing and the other thing goes wrong, and eventually you're not able to deliver the therapy and you lose them. So is there any other better approach where we can, manage these kind of patients? Because they often present late, diabetes is common, and they've been passed off as diabetic nephropathy for months before amyloid is diagnosed.
Absolutely. And this is not just, anything particular to India or, population in India or physicians in India. This happens here as well, and this happens everywhere. And advanced AL amyloidosis is very, very difficult to treat because our therapies include bortezomib, which has significant GI toxicity, significant cardiac toxicity, significant hypotension. We treat them with dexamethasone, which causes worsening of fluid retention. So in these patients, what I have generally done is I start out with single agent subcutaneous daratumumab. I'm not sure if subcutaneous daratumumab is available in India yet.
No, it's not, ma'am. No.
I know it is. I know that it is not available because intravenous daratumumab, again, it's a long process because patients, that they react to it, they need to get a lot of fluid load with it, and then they are there from 8 in the morning till 6 in the evening, trying to really just gradually increase the dose of daratumumab. So I think it makes it very challenging. But I would recommend to at least start with single agent dara, do it for 4 weeks, 6 weeks, 8 weeks, with the hope that the plasma cell dyscrasia goes down, the free light chains drop, and if there is any suggestion of free light chain toxicity or soluble precursor protein toxicity, then the organ should improve quickly, and then you should be able to dose escalate / escalate therapy with addition of bortezomib. I always start bortezomib at 0.7 milligrams per meter square, and then gradually escalate it depending on tolerability. And dexamethasone, I try to avoid in these patients completely, unless they improve in the first 3 to 6 months. Or
Thank you.
whatever you need to do for daratumumab, the pre-medication. But otherwise, I don't dexamethasone. I avoid at all costs.
Right. Thank you very much. I think that's my question.
Thank you, Dr. Shilpa. Dr.
Thank you.
Jatin Sarin, your question, please.
Thank you very much. And as usual, Dr. Vaishali, it was a wonderful lecture. Every time you just mesmerize us with these beautiful things about such a rare disease. Just want to ask that we are still attacking that plasma cell clone in AL amyloidosis. Do you foresee those therapies against amyloid fibrils to come in front, especially the patients who have very poor organ function and they really behave very badly and they're not able to take full therapy and finally succumb to the disease and all. So do you foresee such agents like doxycycline has failed and now there are some antibodies coming? So do you foresee that they're coming in the first line or so?
Right. So, so the clinical trials are ongoing, and these are all randomized phase 3 global clinical trials with 350 patient accrual goals. And the KLM 101 is the antibody, which used to be called 111F4, which is promising in phase 1, phase 2 data. Now, the clinical trials are for stage 3A and stage 3B AL amyloidosis. And the primary endpoint is survival. Because these patients are, their median survivals with standard of therapy is, for 3B is less than a year. So I'm not really sure how these trials are going to pan out, but they are ongoing. That's our hope that yes, that these agents will be beneficial to patients. And then, can be, for what Dr. Shilpa was saying, that a patient like hers who has really end stage advanced amyloidosis, can we use antifibril agent first, improve the organs, and then deliver more specific and definitive therapy with cyborg data? So again, I think that these are all good questions, but I think these trials are not going to be done till I think probably 2024. And then the analysis and reporting of results will be probably 2025. So we will not have that data. Birtamimab is another antibody which was, it failed. So Pronto trial was a phase 2B trial for patients who had persistent organ dysfunction. They were treated with this birtamimab antifibril agent, and that failed. So that trial was stopped. Vital trial, which was a phase 3 newly diagnosed patient trial, which also failed. But on post-hoc analysis, they found that stage 4 patients, so Mayo 2012 staging system, stage 4 patients, there was a survival advantage with birtamimab as when combined with standard of care. So now they are doing a trial to really see if that really holds true, and it is actually mandated by the FDA that this trial be repeated to really show that yes, in stage 4 patients, this antifibril agent is beneficial. So we don't know, these trials are ongoing. And we've learned from our experience, that you said doxycycline was looking very promising, but from China, they did a randomized clinical trial and there was no benefit of overall survival. Again, so it was a failed trial. Doxycycline in phase 2 trials from Medical College of Wisconsin, as well as from UK National Amyloidosis Center, was very, very positive. So, I think that phase 3 placebo-controlled trials are the way to go. Unfortunately, this is a rare disease, and that's why there were not too many trials that were ongoing over the years.
Thank you. Dr. Javed Bhatt, you have a question? You were raising your hands. Yes, Dr. Javed. Sir, you are mute. You have to unmute yourself. Sir, you are muted. You are muted. You need to unmute yourself here. We cannot hear you.
Okay, sir.
Yes,
Okay, sir.
yes. Okay.
Okay, sir. It is okay, sir.
Yes, yes.
I want to actually carry on the question of the Jaitan Sarin. Previously, we knew that these anti-myeloid fibril antibodies, they didn't work at all. But because you know the mesh formed by the fibrin is different, so there is no particular target for these drugs. That's one. Second is that there was a trial started, KEEL trial, CAEL 101. That trial was started around, I think, 3-4 years back. So there was a lot of hope about this trial. Maybe Dr. Vishal makes us educated about that whether the results of that trial are satisfactory. And that is, and the second question I have is that why only some these proteins are amylogenic, while as others are not?
The second question, I don't know the answer to. I don't really know. And what really happens, why some good proteins, I have light chains in my body too, you have light chains in your body, and why do they decide to become amyloidogenic? And we don't really understand it, why amyloidogenicity and why they start making, and why not all myeloma patients, they have high levels of light chains as well. Why they don't develop AL amyloidosis? Only 10% of myeloma patients develop it. So there's a lot to do with, I think, light chain variable regions, gene sequencing, gene usage, and what really happens, whether it is environmental, whether it is toxin related, we don't really know. So I think that is a question that is easy. I think the antifibril agents, I always feel that is there a lot of hope, or whether this is just hype? We don't know, because we have learned from all the small phase 1, phase 2 trials that they look very, very promising. And then when they undergo phase 3 evaluation, these trials are negative. EGCG, doxycycline, all these trials were, the green tea extract, EGCG. Again, that was a phase 3 trial, was a negative trial as well. So I think that, what happens in vitro, we don't understand what is happening in vivo. Moreover, there is no transgenic mouse model to really, really assess these agents in animal models. So that is, I think, one other problem that we have. At the International Society of Amyloidosis meeting in Heidelberg, a French group presented the transgenic mouse model data. So they do have now a transgenic mouse model, which again is little difficult for me to understand, because they were trying to make amyloid in this mouse with insertion of amyloidogenic light chain, and they were unable to for 15 years. We at Boston University, we tried that as well, and we got little amyloid deposition in the GI tract of the mouse. But what they did was, now they deposited recombinant protein-derived amyloid fibrils, and they've injected them into the mice, and that acts as a seed, and more amyloid formation has happened, and now they have multi-organ involvement of the mice. But I don't really understand the standardization of this mouse. I don't understand why seeding in one place should cause amyloid deposition all over. But I think these antifibril agents are all the companies that make antifibril agents are very excited about this transgenic mouse model. And they all want to try their compounds on this mouse model. So, and the KLM 101, the NEOD 001, all those trials are ongoing. We don't have results. It remains a rare disease. These are global trials. They've opened up 150 sites all over the world, but it is still a rare disease. So these trials, they do take several years to accrue and then analyze and complete. And majority of these trials are event-driven trials. So it's not that you enroll 350 patients and then after 12 months, you are going to analyze the data. Both these registration trials are event-driven. So, out of 350 patients, 380 have to die or undergo heart transplant or renal transplant or develop something. So those events are not happening because we have effective therapies. that would be my answer.
Thank you.
Yes.
Thank you, Dr. Shah. Thank you so much.
Thank you, Dr. Javed. We have a question from the audience. Dr. Ashutosh Panigree wants to know that if plasma cell clone is less in the bone marrow, how to diagnose AL amyloidosis? That is his first question. And he has got second question. What is the management of myeloma associated with AL amyloidosis?
So, the plasma cell clone, so I think that only 2% of patients would not have demonstrable systemic plasma cell clone, either with the bone marrow or with immunofixation or with serum-free light chains. So so we published this in, I think, Amyloid journal called Zebra Without Stripes. And, we had sent all those bloods and urines to Mayo Clinic laboratories to do mass spectrometry-based detection of monoclonal protein. And we were unable to identify that as well. But they were diagnosed as AL amyloidosis based on mass spectrometry on the tissue, either, kidney or heart or GI tract as lambda. So, and they had multi-system organ involvement. It was not localized amyloidosis. It was multi-system. The 3 of those patients out of 5 or 6 that we reported on had nephrotic syndrome. And I think the problem happens that we know that there is a plasma cell clone somewhere that is producing this amyloidogenic light chain, but we can't demonstrate it. So we do treat them with anti-plasma cell therapy. I've not really taken anybody through stem cell transplant because I don't want to kill them and not demonstrate the plasma cell clone. But we do treat them with non-stem cell transplant regimen. But then what do you follow? Because there is nothing to really follow. And then you are relying on the proteinuria, whether the proteinuria gets better or not. And we all know that proteinuria doesn't get better for 12 months to 2 years. And we also know that only 50% of patients would have organ response, even if you deliver the most effective plasma cell clone therapy. So, it's a very, very challenging situation. And, it's a great question. But, you have to make sure that you've done everything to demonstrate the plasma cell clone and accurate typing. Because are we dealing with some other type of amyloidosis and it is not light chain derived? That is, I think those are the 2 important messages that I have for that. And then myeloma associated AL amyloidosis, I think majority of those patients have soft tissue involvement. They can have nephrotic syndrome, but then you have to treat myeloma. So those patients, I would recommend maintenance therapy. I would recommend induction therapy. So that is myeloma. But the tolerability of treatment is going to be difficult because the organs are beat up. Because, organs have amyloidosis. So the tolerability is going to be definitely an issue. And they are not going to be able to tolerate immunomodulatory agents, lenalidomide at 25 milligrams a day. They will require dose reductions. In AL amyloidosis, I usually start at 15 milligrams a day. So we did a phase 1, phase 2 trial, and the maximum tolerated dose was 15.
Thank you, madam. Dr. Ashutosh has got another question. How do you manage bradyarrhythmia in your patient with AL amyloidosis?
Right. So bradyarrhythmias, again, I'm not a cardiologist, but I think that those patients should definitely be evaluated by electrophysiologists. Make sure that, they don't require a pacemaker. But, we obviously, beta blockers are, that's why I say supportive care is so crucial, because digoxin is contraindicated in patients with AL amyloidosis. Beta blockers are contraindicated because patients feel terrible, their blood pressures drop, and they cannot handle it. So I think bradyarrhythmias would be, again, EP evaluation and possibility of pacemaker.
Thank you, ma'am. Dr. Vinayak Chikodi, he has a question that is beta-2 microglobulin deposition alone responsible for dialysis-related amyloidosis?
So beta-2 microglobulin associated amyloidosis was historically seen in patients who were on dialysis. We don't see that anymore because the dialysis techniques and the dialysis membranes have gotten much better. So there is not accumulation of beta-2 microglobulin. And the clinical phenotype with beta-2 microglobulin associated amyloidosis is usually soft tissue involvement. They get a lot of arthropathy and soft tissue deposition. They have, shoulder pad sign. They have arthropathy involving shoulders and wrists and things like that. They generally don't have organ involved, but it is historical. We don't really see that any longer. I think the question is, why is the patient on dialysis? And is dialysis end-stage renal disease is associated with some sort of amyloidosis that was not identified, and now you are seeing that, okay, beta-2 microglobulins are elevated and whatnot. So I think that again, a lot of patients are on dialysis and then they come here, and that is how the whole process starts. But what is the cause of renal failure is important at that point.
Thank
But
you.
these are usually wild-type beta-2 microglobulin. So there is no mutation in beta-2 microglobulin. It is just that it just constantly is accumulating because the dialysis membrane is unable to take beta-2 microglobulin now.
Dr. Kannan has a question that when do you consider high-dose therapy for AL amyloidosis?
Right. So as I said in the talk, that the eligibility criteria for high-dose chemotherapy and stem cell transplant vary from institution to institution. It is all based on your experience. It is all based on your comfort level. It is all based on what your standard operating procedures are. Majority of the patients are not eligible to get stem cell transplantation because of cardiac involvement, because of poor functional status, because of renal failure, because of autonomic neuropathy with systolic blood pressures of less than 90, because of severe acquired coagulopathy from factor 10 deficiency, because of GI bleeding, because of GI amyloid deposition. So only 20% of patients with new diagnosis of AL amyloidosis are eligible to receive this therapy, even at my institution. So, I think that it is difficult. Last time when I did this talk a year ago, there was a question that they had transplanted. I don't remember which institution it was from, that they had done 5 stem cell transplants for AL amyloidosis and 3 patients had died, which is very typical when you start off. And these patients are sick. So I would probably say that, that you have to be, so we have published on ISA guidelines for treatment guidelines for eligibility for patients with AL amyloidosis for stem cell transplant. And I think you should look at that because that also talks about specific supportive care. We lose patients during stem cell mobilization and collection phase of treatment because of capillary leak syndrome, because of fluid gain and fluid overload from just the growth factor administration. Because the amount of growth factor that you require to mobilize stem cells is 16 micrograms per kilogram per day of GCSF, and that can cause severe fluid retention. So we've been through a lot, and these patients, they do experience a lot of complications.
Thank you, ma'am. Dr. Karim, I think the question has been repeated. Dr. Karim has a question that sometimes you don't see any plasma cell clone identified, and free light chains are very, very low in the blood and urine. So it is not identified. And this patient is present to you with organ dysfunction. So how can you go for early diagnosis for these cases?
Right. So early diagnosis and increased awareness are 2 major focus of my career, I think. That, I think that I feel that, I work in Boston, and Boston is supposedly the Mecca of medicine. And we have 5 very high profile medical centers in the radius of 5 kilometers. And they have huge myeloma programs. Dana-Farber Cancer Institute, Dr. Ken Henderson, Dr. Paul Richardson, Dr. Nikhil Munshi, these are all huge names. And they have patients with myeloma. And their group also fails to recognize the red flag symptoms of AL amyloidosis: macroglossia, arthropathy, soft tissue involvement, spontaneous bruising, because their platelets are low And yeah, they all are on dexamethasone. So the macroglossia is blamed on fluid retention. Macroglossia is blamed on oral candidiasis. Macroglossia is blamed on something else. And these red flag symptoms are not being diagnosed. So the increased awareness is the way to early diagnose. We always do abdominal fat pad aspiration and subject it to Congo red. Now, it is a very non-invasive procedure. Again, as I stated earlier, 70 to 80% are positive. So if that is not, then you may need to biopsy the tongue, or you may need to biopsy minor salivary glands, or may need to biopsy rectum. But again, that I think that recognition of symptoms is the only way to diagnose them early. There is also a lot of movement in patients with monoclonal gammopathy of unknown significance that 1% of these patients would develop AL amyloidosis, during their journey, and can we diagnose them early? So patients who have monoclonal gammopathy of unknown significance, if it is a lambda clone or lambda MGUS, then we do, at least I would recommend that do cardiac biomarkers and urine analysis once a year, once every 2 years, just to make sure that you are not dealing with early development of AL amyloidosis.
Thank you, ma'am. Dr. Mohammad Karim has a question. High dose therapy followed by autologous stem cell transplant. What high dose therapy would you like to practice? Dara-Cybody or only Cybody?
Right. So I'm looking at the question, so I'm not really understanding that. Obviously, high dose therapy is melphalan based, and that is a conditioning regimen prior to stem cell transplant. So stem cell transplant is not really the therapy. The therapy is the high dose chemotherapy. But that is, as I said, only 20% of patients are eligible to get that. 80% of patients require standard therapy, which is non-stem cell transplant based. And then the question is Cybody versus Cybody-Dara. Cybody-Dara, as shown by the Andromeda clinical trial, that hematologic complete response rate, organ response rate, and quality of life data also show that Dara-Cybody is better than Cybody alone with respect to those parameters. We don't have data on overall survival yet. We don't have data on major organ deterioration, progression-free survival, which are their secondary endpoints. We don't have long-term follow-up data that what is, how quickly do the patients relapse after you stop daratumumab, because this trial administered daratumumab for 2 years. So after 2 years, what happens? And I'm not even sure that in India, whether administration of daratumumab for 2 years is financially possible for any patient, because probably it is still a very expensive drug,
It's expensive.
Yeah, very expensive, right? I know, because my sister's mother-in-law has myeloma, and they can't afford it.
Dr. Ashutosh has a question. Can we send sample to you for diagnosis, and what would be the cost?
I know. So I know that Ashu Wecklecker from National Amyloidosis Center, they have set it up very nicely. So a lot of specimens from India go to them for immunohistochemistry, for accurate typing, things like that. We don't at Boston University, we don't really have a mechanism where we have done this. I generally, we've done several second opinion consultations, and because of the advent of Zoom, I think it is easier to do. But I think the specimens, I always recommend to send them to Mayo Clinic laboratories, because it's a big, huge business operation. And I think they have standardized procedures and whatnot. They are not part of Mayo Clinic, but it's Mayo Clinic laboratories. And, I think that is what I would recommend if the specimen has to come here, rather than, not going to UK National Amyloidosis Center.
Thank you, ma'am. So what would be the cost actually? Any cost issue?
Right. So I think cost is, I will tell you, it is $900 to $1,500 for mass spectrometry. So I know that is the pricing at Mayo Clinic, because, when my patient specimens also go there for mass spectrometry, they do make them sign it that if the insurance doesn't pay for it, they will have to pay on their own. So it is about anywhere from, I think, $1,000 to $1,500.
Thank you, ma'am. We have finished the question from the chat box. Anybody else has any question from the discussions? Yes, sir. Please go ahead, Dr. Javed. You're muted. Yeah, you have to unmute yourself. Yeah.
And after 3 years of this pandemic, we would, we all are in the same boat.
Madam, Dr. Vishal, I have two more questions. Is that can amyloid of the gut present as ulcerative colitis, a sole presentation as a sole presentation? And the second question is that before symptoms or the full-blown presentation, how many years before we can detect the monoclonal component in the serum?
So the first question about GI involvement, that yes, absolutely. They can present as weight loss. They can present as GI bleeding. They can present as diarrhea. And it doesn't have to be other organ involvement. It can be just localized GI involvement. And localized GI involvement at times can be very, very morbidity causing, because patients are having a lot of GI bleeding, they're having a lot of diarrhea and other GI symptoms. So yes, but so ulcerative colitis is a different diagnosis because it's a inflammatory bowel disease. So again, I think that the endoscopy, colonoscopy has to be done, and it has to be again biopsied and undergo Congo red staining to differentiate between amyloid deposition versus ulcerative colitis. And the next question is, how many years before the full-blown clinical phenotype can we detect the monoclonal protein? So there was a study done by Brandon Weiss when he was at University of Pennsylvania, or when he was in the Army, that patients in the Army of US Army who developed AL amyloidosis, because before they enter the Army, they all give blood. And apparently their bloods are saved for a long time. And he did this study, and 100% of the patients did have evidence of monoclonal protein anywhere from 5 to 15 years prior to diagnosis of amyloidosis. So yes, that it is quote unquote like myeloma, that all myelomas are preceded by MGUS and monoclonal gammopathy. So I think it is something similar to that. I think what we don't know is how can we really identify and detect it early? So there are some trials and grants and research going on that can we detect any specific type of lambda light chain variable region gene usage in those patients with MGUS, and predict that yes, these guys are going to get AL amyloidosis, but are you going to start treating them? We don't really know what the implication of that would be either.
Thank you, Dr. Vishal, so much.
Thank you
for nice answers.
Your question? You have a question?
Ma'am, my question is in continuation with what Dr. Javed just said. So just like iStop study, do you look at iStop amyloid kind of study in future for amyloidosis screening? And second question is there any difference in the phenotype of the NRI patients, the patients of Indian or Southeast Asian origin from the natives in United States?
Excellent questions. So I have to move to Iceland to really do iStop amyloid study. It's just totally amazing. 75,000 patients in iStop It was just amazing data. And I think the issue is, or not the issue, the iStop study, the AL amyloidosis was less than 1%. So it is again an extremely rare disease. I think that we are recognizing it better. We have increased awareness. So we feel, and we had a poster at ISA at the Germany meeting, where it was the same patient journey that was published in 2015, done by the same patient-led organization, where they found that now the diagnosis, the patient journey is much improved. The diagnosis is sooner. They are seeing less number of physicians to reach the diagnosis, and they are also the duration from initial symptoms to diagnosis is also decreased. So I think we are making an impact by doing all these conferences, by doing all these webinars, by doing all these educational sessions at multiple national meetings, international meetings. I think that we are making a difference. There's no question. I think the second question is, and iStop-MM, the amyloid patients, AL amyloidosis was very, very limited. The difference between, obviously, I'm from India. So I feel very strongly, and I get a lot of emails and, correspondence from physicians and patients and relatives from India. I think that initially, like 5 years ago, I used to always say that make sure that the patient does not have AA amyloidosis, which is secondary amyloidosis. Historically, it was known as secondary amyloidosis, because patients in India, like all of us, do have this underlying tuberculosis, infections, bronchiectasis, and all those inflammatory causes can upregulate serum amyloid A protein, leading to formation of amyloid fibrils and leading to nephrotic syndrome. Usually it is hepatomegaly, splenomegaly, and nephrotic syndrome. So those are the three organs involved. So I used to always tell everybody that make sure this person does not have AA amyloidosis, because obviously the treatment is different. You treat the underlying cause, treat TB, treat juvenile rheumatoid arthritis, treat the infection, and things would get better. Now, having said that, in the past 2 or 3 years, I've had a lot of emails about hereditary TTR amyloidosis. And it is amazing what we are seeing or what I'm getting. There are different or weird mutations present. The neurologists are picking this up because they have neuropathy, they have neurological symptoms, and and they are doing genetic testing. There are a couple of people from Hyderabad who have had it. There's a person, I think, also from North, who has this. And I think I used to always feel that V30M TTR mutation is common because of the Portuguese colonization in India. And, there was some mixed breeding. And maybe that's why, that we have V30M TTR. But, I've seen different types of mutations now. The problem is that TTR amyloidosis, we do have gene silencers and TTR stabilizers that are FDA approved in the last 3 years that are available here to slow the disease progression. In India, none of these medications are available. And it is really challenging, and these are lifelong medications. They take about $250,000 to $500,000 a year to deliver over here. So even if the patients move to the United States, they cannot move to the United States for the rest of their life. So I think that is a big challenge that I face, and I don't really know how to help patients, who have achieved a diagnosis, but then there is nothing to do. And, they're going to have it in their children. It's an autosomal dominant hereditary type of amyloidosis. So I'm seeing that also. Obviously, we have seen AL amyloidosis. I think we have seen AL amyloidosis. I think I've seen a lot of heart amyloidosis, cardiac involvement. Some of the patients have come over here. Some of the patients have stayed there. I have several patients from there who came here for an opinion. We confirmed the diagnosis. Then they went back and they got treated by the physicians there. And then we stay in communication with the physicians or with the patients. Patients are pretty smart, and they know how to, send emails and reports and all that. But I think AL amyloidosis is on the rise because of, I think, recognition and awareness. And I think the options for treatment. We have Cyborg-D that you can give in India.
Thank you, ma'am.
Thank you, Dr. Aditya. We have a question again, as I think repeat question. Dr. Mohammed Karim wants to know that if your patient is a transplant eligible case, then only direct autologous transplant can be done frontline. And after transplant, do we need to go for maintenance?
It's an excellent question. And, fortunately, I wish, there was more time so I could have presented all the data. But, in general, I do, because I know that there are a lot of questions about transplant. So I do recommend for you, and maybe, I can send it to Dr. Khurana or Dr. Agarwal, the article, it is the guidelines. It was developed by experts in the field of transplant and AL amyloidosis through International Society of Amyloidosis, and it was endorsed by European Hematology Association as well. That what we recommend, majority of the patients have less than 10% plasma cells. So in those patients, I take them directly to stem cell transplant if they're eligible. Okay? I preface that by multiple times saying that if they're eligible. But if they have greater than 10% plasma cells, then we would recommend few cycles of induction therapy. If, in few cycles, meaning either 2 cycles, 3 cycles, 4 cycles, something like that, followed by high-dose melphalan stem cell transplant. We definitely don't recommend maintenance unless they fit the criteria for myeloma. Now, the problems with induction therapy, we had a prospective trial at my institution, investigator-initiated trial, and we also have a prospective trial from the European group, the EMN trial. No, it was not EMN, it was HOVON trial. And both these prospective trials treated patients with 2 to 4 cycles of induction therapy with bortezomib-based therapy, so CyBorD, followed by stem cell transplant. And the patient attrition rate, meaning that patients who were eligible to get stem cell transplant, but they were treated with induction therapy, and then they became ineligible to get stem cell transplant because of clinical deterioration, because of organ failure, because of worsening of autonomic neuropathy, happened in 14 to 35% of patients. So the most definitive treatment, which was stem cell transplant, was unable to be delivered to these patients because of complications of induction therapy. So we don't really want to undermine those data and say that everybody should get induction therapy. I am a strong believer that if the patients have less than 10% plasma cells, there's no role for induction therapy. Greater than 10%, maybe. In my practice, I usually do more than 20%, then I would do induction therapy. And it should be weekly bortezomib-based. One more thought about CyBorD DARA. In the safety run-in part of Andromeda clinical trial published in Blood, there were 28 patients treated with the CyBorD DARA. Out of 28 patients, 9 patients underwent stem cell transplant. Of those 9 patients, there were 3 deaths. So it is 30% treatment-related mortality, which is unreal. And the question is, did DARA play a role in worsening something? There's a lot of CD38 expression in the cardiac myocytes. And we don't really know whether DARA had anything to do with this increased treatment-related mortality post quote-unquote induction therapy. So in the guidelines that we have published, I don't recommend DARA-based induction therapy. I would say bortezomib-based induction therapy, that means CyBorD, 2 to 4 cycles prior to stem cell transplant if plasmacytosis is greater than 10%. And definitely no role for maintenance unless they meet criteria for myeloma.
That's brilliant, ma'am. Dr. Priyanka Samal has the question, I think it's a repeated, any role of maintenance in AL amyloidosis?
Yeah, no.
No role.
I think, those of us who've taken care of patients with AL amyloidosis, you know that they are very frail. You know that no matter what you do to them, they have a tendency to develop complications because their organs are not normal. And, the proteinuria and cardiac biomarkers are surrogate markers of organ dysfunction. We don't really know what is happening in the organs because organs could be really, really, really bad. And I would say that, I think goal is to achieve a hematologic response and then wait for the organs to respond while providing best supportive care. the organs will respond. Even if the protein in the urine goes down from 18 grams to 5 grams, patients are going to start feeling better. We are not striving for protein in the urine to be less than 200 milligrams. But even if it is down from 15 grams to 5 grams, patients will start to feel better. So I think that do no harm should be the first goal.
Thank you so much, ma'am. You've finished all the questions. I may say you are brilliant, excellent. No words for you.
I just do this disease, so that's why I can focus on this.
It was a beautiful presentation, excellent presentation, and what a discussion. Thank you, ma'am. Hats off to you.
Thank you. Thank you. Thank you very much. Really appreciate you guys all spending your Saturday evening with learning about AL amyloidosis. And as I said, that I remain available for any questions. You have my email. You can email us at amyloid@bmc.org. And that always comes to me. We always, any logistical questions, it is managed by one of my program managers, and she's pretty good and she is able to answer a lot of questions as well. So
thank you so much. Thank you, ma'am. Thank you so much.
Very welcome.
I now hand over
and say hello to Dr. Agarwal for me.
Sure,
and
sure.
I will send over the stem cell transplant guidelines, so that at least you can distribute it or put it on your website, so that the physicians who have questions can address, because it is a comprehensive and it is kept in mind all the institutions with experience, without experience, so that they can develop. It has a section on supportive care, which is also very critical.
Thank you so much, ma'am. Thank you so much.
Thank you very much. Namaste.
Namaste. I now hand
Thank
over
you, ma'am.
for the final vote of thanks to NATCO. Please take over. Is NATCO people available? NATCO is not available. Okay, fine, ma'am. Then that was great. Thank you so much. Again, a goodbye to you, and so nice to hear from you.
Thank you. Take care. Bye-bye.
Okay.
Bye.